my disclosure. It's getting harder and harder to convince parents that habit behaviors don't represent some serious psychopathology. So in looking at this definition, I want to draw your attention to a couple of things. One is the fact that the behaviors occur in the context of normal development and that they resolve without specific treatment. And what I find is that some of the, let's take for example, something that I hear very often. My child is lining up the toy soldiers. If you look at the cover of the box of these toy soldiers, you know the little green ones, guess what you see? They're actually lined up on the box. Louder? Yes. Or they're lining up their cars. If you go in a typical parking lot, I guess the cars are actually lined up. So trying to differentiate habit behaviors from the next category, which are sort of close in terms of their presentation, is important. So I wanted to make the differentiation between habit behaviors and stereotypic movement disorders. And the most important difference is that these behaviors occur in the context of a child who has a developmental or a behavioral disorder. So I wanted to make that point because as we go along, we're talking about typically developing children. Okay. All of us have habit behaviors. I guarantee you that at least half of us in here chew gum. Do we have a habit behavior? Actually, we do. And oral behaviors happen to be the commonest of the habit behaviors. And overall, about 15 to 20% of children will have a habit behavior that will manifest itself before the age of 3 years. There are a number of etiologies. For example, pain or anger, frustration, fear is associated with breath holding. Some are sensory-seeking behaviors, as in thumb sucking, anxiety with nail biting, and with the onset or the emergence from sleep, head banging and body rocking. And we're going to be talking about those. But I just want to emphasize that habit behaviors do not represent disease entities. There are specific activities that are associated with certain stages of development. This is not always the easiest thing to convince parents of. Okay, let's talk about thumb sucking. Thumb sucking is probably the earliest of all the habit behaviors and can be seen in the womb. And up to 90% in some studies, 90% of kids under the age of 2 will be sucking their thumbs at one point. Actually, it's interesting to know that thumb sucking was not always felt to be a problem until relatively recently. So if you look at paintings from the Renaissance era, for example, a lot of times you'll see kids with their thumbs in their mouths and they're looking quite tranquil and happy. It's not until the late 19th century that thumb sucking became a problem that needed intervention and treatment. And let's look at a case scenario. And this is coming from the boards. So a 3-year-old boy, mother calls for advice. She's concerned because her son sucks his thumb despite her best efforts to prevent the habit. First thing is that bandages don't work. Barriers of any sort don't work. And they work only maybe on the first day for a couple minutes at a time. Timeout doesn't work. Now, let me just say, in terms of negatively reinforcing a behavior, the fact of the matter is if you're sufficiently harsh, you can extinguish any behavior. But that is not what I'm referring to here. Using a bad tasting substance, this is one of the best examples of a disconnect between what parents recognize to be something that's effective and what we recognize to be something that's not effective. It doesn't work. I think everybody has tried this at some point. In fact, there's an industry out there that makes bad tasting substances, even though it never works. How about splinting of the elbows? This is one of the things I refer to as being excessively harsh. The fact is, it does work. If you splint an elbow, the fact is you can't suck your thumb. I have to confess that I have used a splint on an elbow, but this was a child who was hospitalized, who had had multiple abdominal surgeries because he had bowel obstruction from bezoars, and he was severely mentally retarded. And so the thumb sucking was a part of a larger pattern of behavior of putting things in his mouth. And so it wasn't there, and he had gone down to the bone at one point and got an infection. So this was sort of an unusual situation. But again, I'm referring to kids who are typically developing. Okay. So I guess you can sort of figure out from this that the answer is going to be D. So we reassure parents, ignore the kids under 4 years because it will usually remit by latency. Latency meaning around the age of 7 years. And positive reinforcement with praise and rewards for not sucking your thumb. The bandage that's used, if you're going to use a bandage, is not there as a barrier. It's there as a visual reminder that you're not to suck your thumb. And what about a thumb crib? Well, the word may is there, and may refers to those small number of kids who may actually open a wound, may have an infection, or there may be some injury of some sort. You may want to consider referral for a thumb crib. And a thumb crib is just a little device that prevents you from getting your thumb much beyond your incisors. I'm sorry, but I'm fighting off the flu here, and I'm doing the best I can. Okay. What about nail biting? Nail biting generally occurs in the context of some tension situation. Excitement, fear, nervousness, and anxiety. Anxiety is the primary state of tension that results in nail biting. For the most part, as with all the habit disorders, we recommend ignoring this, keeping the nails short. It probably makes sense to do a careful history to rule out an underlying anxiety disorder, particularly in older children, because there's a very strong association between nail biting and anxiety. And what if all of these don't work and you're getting instances of paronychia and other types of nail infections? Habit reversal therapy, which I think we're going to hear more about at the next section. Habit reversal therapy consists of a number of different components. One is you want to increase awareness of the habit. And so the first step in doing this would be to have the child look in the mirror and look at themselves biting their nails. Because the fact is they may not be aware that they're doing it, and very often it's something that's done subconsciously. Teaching a competing response. The truth is what you're actually doing is substituting one habit for another habit. And not unlike smoking, where you end up chewing gum, which is another means of oral gratification. But in this instance, chewing gum is felt to be less typical, or more typical, I should say. Blowing air through pursed lips, another competing response. And then relaxation techniques, visualization, deep breathing, progressive muscle relaxation. These are things that can be taught in the office over a short period of time. If none of these work, then you can consider hypnotherapy if habit reversal therapy is not successful. There's something called a mouth guard that will interfere with your ability to get your incisors opposed to each other, and you may want to consider that if none of these work and the child is actually, as I said, getting paronychia or other types of infections. I'm going to hold my breath until I pass out. How many parents can ignore this? There are 4 types of breath-holding spells, and they're all equally disturbing. The simple breath-holding spell, where the child will, typically it's in response to frustration, or sometimes it's a tantrum. We have the cyanotic breath-holding spells where they have a Valsalva maneuver typical in response to pain, but again with frustration. And the pallid spell, which is difficult to differentiate from a seizure. And then the complicated spell, or the complex spell, which is sort of a combination of the pallid and the cyanotic spell. Here's a case scenario. An otherwise healthy 1-year-old girl has had several episodes in which she becomes cyanotic and loses consciousness after crying. She's brought to the office an hour later. She's alert. She takes a few steps. She says mama to her mother, and the physical exam findings are normal. What do you do in this situation? Admitting her to the hospital is not indicated. CT scans of the head, an EKG for conduction defect, or an EEG. The answer, of course, is to reassure the parents, except in a number of situations. Let me just describe the exception here. If, by taking a history and a physical exam, just note for a moment, child is developmentally normal, you can't really tell on the basis of your exam or based on the history whether this is in fact a seizure or not. What I have done in the past is, because every cell phone has a video camera on it now, I have asked for a video of the event. And I must tell you, in some situations, I really can't tell whether it's a seizure or not. And in those instances, I think it would be appropriate to get an EEG. But the ability to have a video of the event has made it a lot easier to assess and to intervene in these situations with breath holding spells. So what specifically do we tell the parents? They should remain calm. Do not give attention to, usually it's in the context of a tantrum. And as long as the child is not going to injure themselves, is to leave them alone. Now, what about iron? There are some studies that have shown that up to 90% of kids who have breath holding spells will respond to supplemental iron. The ones that give such a high efficacy tend to be very small studies. But there's a whole issue of giving medication for something that in general doesn't require treatment. So there's some division about whether you should do this or not. But if the child is anemic, there is an association between iron deficiency anemia and the severity and the frequency of breath holding spells. The reason for this is not really clear. Okay. All right. Head banging and rocking. So this is the position that is taken up in the crib. You're on all fours, and then you're going back and forth and back and forth. And either your head is banging against the railings, or the entire crib is banging against the wall. So here we have a case of a 2-year-old who's banging her head on the crib side rails at age 10 months, and she continues to do it most nights until she falls asleep. Medical history is unremarkable, except for a simple febrile seizure at 12 months. She walks well, has a vocabulary of more than 50 words. Her physical exam is normal. What do you do with such a patient? An EEG is not indicated. Referral for a neurologic evaluation is not indicated. An eye exam and a psychiatric evaluation is not indicated. So no intervention is indicated here. So what do you do in such a situation? A couple of things. The head banging, the rocking typically starts first, and it's followed by the head banging. Head banging will go away, and the rocking may persist, sometimes for a pretty long time. Reassuring the parents that it rarely results in injury and will usually remit by the age of 4 years. And again, you don't give attention to the behavior, and if you're still concerned, the concern that I'm usually presented with is that there's a lot of noise, nobody can sleep, the child is not sleeping, we line the crib with a bumper pad, move the crib away from the wall. Now, what if it persists much beyond 4 years? There may be a need for further evaluation, and you would have to reassess the development of the child at that point. Okay, And here are our references. Any questions? Yes?
What about hair pulling?
Hair pulling, interestingly, hair pulling along with pulling on the ears, rubbing the clothes is associated with thumb sucking. Now, you're referring to trichotillomania itself. Typically, it's anxiety-based, and relaxation techniques may work. Habit reversal therapy may work. And I have had success as well with anti-anxiety medications. Another question? Okay. Good. All right. Thanks. The wire. Oh, yes. Ran away with the wire. I'm taking it home with me.